So yes, at Matibabu, we are a medtech company that is fighting mainly to close the gap between the communities and their rightful access to healthcare. And the way we do this is by providing solutions that help accelerate the process of receiving healthcare in the communities. This can be web systems, it can be devices that aid diagnosis, so that we see that the people in the communities can have quick access to the healthcare that they need. So as we all know, current diagnosis of malaria is mainly done by two practices. So one can be the RDT or the strips that take around 15 minutes for a diagnosis, or a microscope that takes about 30 minutes. That's from the time blood is drawn from the patient. Actually, this process is quite tedious, and it's tedious to the two sectors that are involved. That's the patient, because they get to wait for long lines like most of us have been in this situation, but also for the health practitioner that gets to work long hours to make sure that they deliver the health service that they're required to deliver. So that's why we at Matibabu developed a kit that is actually 15 times faster than the normal methods, but also with the possibility of collecting data in real time. What we use this for is to help get all this data into the dashboard, and then help people that are making decisions at a control, at the vector control level, maybe at a country level, so that they make informed decisions of what is happening. So to talk about our process today, we have been in development for the last 4 to 5 years. So this has been a very challenging process of development. And this is just a simple timeline to show you that what we have actually gone through to get to the point where we are. So we started off over 5 years ago with an intention of non-invasive malaria diagnosis. And we managed to put together a simple prototype then without any advanced technical expertise, or without a team that is actually well informed about what we're going into. Most of us on the team were people with a software engineering or computer science background. So, but we decided to give it a go. So for the first two prototypes, we realized the first prototype was actually not very fruitful. What I mean, it wasn't giving off conclusive results. And we realized here we're also looking at very few parameters, just trying to shine light and see how the light interacts with the organisms. But good enough, we realized that there was a lot of interference here, and we moved into the second level of prototypes. But this was only dependent on the insights that we had inward as a team. So, but at this moment, we decided to first take some of these prototypes into the community to really try to test our assumptions and see if we are actually developing what is usable in the community. And this was a need finding survey to just assess the assumptions we had, because our biggest assumption was we have seen a great shift in our medication, but we haven't seen a great shift in the way people do diagnosis. So the assumption was here, can we change the way we do diagnosis and we impact the numbers due to the death from malaria? So we found when we at this level, that's when we also went into the third prototype, and we're trying to just study parameters like the oxygen levels and things like that, how Plasmodium affects these levels. So, and when we went into the communities, one of the examples that I love sharing always is we were trying to talk to the people and were set up in a clinic. The way the study was designed, we were set up in a room, and then people would also go into another room to do the study. And we realized that when we moved into that room, it was a lady moved in with their kid and trying to do diagnosis non-invasively with us. But with the results we gave them, they were not contented, and they had to move into the other room to have their blood drawn. Those insights took us back to the drawing board and tried to see how can we actually develop something that is usable. In most cases, we do aim at developing a very fancy technology, but we end up leaving this technology on the shelves and end up not using this technology. The reason is because we do not take time to involve the community or the people we are trying to develop for. So we find that in most cases you draw a lot of money from a problem, yet you're trying to solve it in a wrong way. So we went back to the drawing board, good enough at an earlier stage, and we're trying to redesign and see how can we actually make this technology usable. And that's when we went through the 4th and the 5th generation prototype that we're actually going in for a clinical trial with Mulago and other sites in Angola, with the main objective of the study being determining the efficacy of the device in comparison to the gold standard being the microscopy. So, but I'm just trying to catch up with them, but that's the process that we're being undertaking. And over time, we've been able to build up a few partners, and we thank our partners for standing with us and working with us. But as I close, I will leave us with only one question. How do we develop usable technology that will actually close the gap between us and the communities? Technology that is actually consumable, not only technology that we want to leave at the sideline. Thank you.
In 2011, I picked medical school to go to computer school. The reason I wanted to be a doctor in the first place is that the one thing I know that I've always loved is help people. But I also had the second love, which was computers. Medical school was frustrating for many reasons. One, the biggest reason for my leaving was, you spend 5 years in medical school, you have that other 1 year to do residency, and yet you don't have the tools that allow you to do your job to the best way possible. So when I went to computing school, the first idea that came to mind was, now I know what happens in medical school, and I'm now a computer engineer, what do you do? So we built Winsenga. What we're trying to help with Winsenga is maternal infant mortality. As you know, it's still a very, very big problem, especially in Sub-Saharan Africa. And there are many factors around it, but one of the biggest issues is around being able to diagnose problems early, and also, very importantly, for me anyway, during labor. I don't know if you have any medical doctors, I don't want to go very technical, doctor here perhaps. So, when you're in labor, we're still using 200-year-old technology, the fetoscope. I'm sure you've seen it. The little cone-shaped thing. Also, we are tracking the progress of your labor using a piece of paper, which is recommended by WHO, by the way. So if I have my gloves on and I have to feel the scene, I have 20, imagine you have an institution, you have 20 different mothers during labor. How are you going to handle that? In fact, in one of our studies, we realized that in Mozambique, for example, midwives never filled in the paper part of it because they just don't have the time. Anyway, so how we're solving this with Winsenga was to, one, provide low-cost alternative to ultrasound. That ultrasound costs you, what, $20,000, or if you get really, a used one, you're still looking at thousands of US dollars. I know there are companies like Philips that have Philips Lumify, and GE also has something similar. But if you're running a subscription model, honestly, for our health center, 4s and above, it's just not possible. When you're running that subscription, it's about the same amount of money that health center is using to plan for the entire quarter. So, but there's one characteristic that we know about Africa now: mobile phones. They're getting cheaper and cheaper. Connectivity is becoming much more prevalent, and also the cost is going much further down. So we thought, what if you could use a $50 smartphone to do most of the heavy lifting that the ultrasound does? And we started this in 2011, and by 2015, we had actually figured out a way of doing it. Small device fits in your pocket, connects to your $50 smartphone, and does the thing that, for a start, in 2015, we're doing our first real prototype. We replace the fetal Doppler. The fetal Doppler, a good one, costs about $600. our device was going for about $50. That's a very, very big drop in pricing. But we also know that you need imaging. So fast forward 2017, we finally figured out how to still do the same thing by offloading most of the processing onto the smartphone. Small $50 phone has a lot of power in it, and that's how that was actually the innovation, by offloading the processing from the one big packaging into the smartphone that everyone already has. But because it's on the smartphone, do you know what else we can do? We can do reminders. We can do records. We can do real time, just by shifting the way you're thinking about solving the problem. That's the background about Winsenga. Now you must be wondering, if all those things are very nice, how is it that I'm moonlighting at Andela? Which brings you to the next section of my talk, which is about challenges. Now, as you know, from 2011, I've been doing this for quite a while, and almost everything that guitar has gone through, or other innovators have gone through, we've gone through. And I just want to highlight some of the things here and how we try to solve them, or how I try to solve them. The very first one I'll talk about is policy and regulations. To the best of my knowledge, we do not have a policy that regulates medical devices in this country. In fact, until 2014, the NDA, our National Drug Authority, only had that. I think towards the end of 2014, there was an edit. Wherever there was a drug, it's a drug/device, which still doesn't help, because there are different things. There's a drug and there's a device, entirely different things. When we were trying to apply for a clinical trial, I remember, in the panel, and we were trying to explain to medical doctors who, not by any fault of their own, it's just new, yeah, so that's a really big thing. You're operating in an ecosystem for whom there are no regulations, So what have we done about that? When I started working with Winsenga, I got into the UN, and I think in 2017 we ran our first e-health conference, just trying to discuss how do you create policy around e-health, and how do you manage data, how do you do all those things. The second thing, challenge, is on funding, and I'm sure I'm looking at Brad here because it's one of the biggest things. When we started out with Winsenga, we got our first grant money from Microsoft, and since then we got some money from USAID and a bunch of other people, but also, believe it or not, the government of Chile. So why would a non-Spanish speaking Ugandan move all the way from a country that Chile doesn't really do any business with to fly to Chile? Funding. It has always pained me that innovators have to go out there, especially African innovators, have to go out there to find money for the things that actually are solving problems for us here. Yeah, and in fact, when you see, even with Brand, the sort of funding that he got is mostly from NGOs, from, all these other multinationals. The third thing I want to talk about is around product, and you also touched a little bit about it, around talent. Outside of Winsenga, I co-founded 3 other companies, and building a team that builds things the way you want them to be built, world class, is really difficult to find here. For Winsenga, I remember we ended up having to outsource to Russia some of our programming. Australia, when we were doing our very first proper prototype, bill of materials from Germany, fly that to Shenzhen, that whole value chain. And that's part of where I'm at Andela. I think that we can create a world that has more, Africa that has more world-class engineers. Lastly, because I'm running out of time, I want to talk about failure. Everyone got quiet. So failure is, and I'm saying failure because after 7 years of running Winsenga, we decided to shut down because it just wasn't making sense anymore from a business point of view. But there are many lessons that were learned, and Part of my being here and all these things that I'm involved in is that there are lessons that I learned there that only having walked through these shoes, you could see. But now how do you, so what I'm trying to say is that failure is an opportunity, and having started 4 other companies, it has become one of my biggest assets, learning from failure and dusting yourself off.
Start talking about the background. HIV is still a burden in sub-Saharan Africa, and over 2017, around 1.3 million Ugandans were living with HIV, and 73% were on ART. We still have a challenge based on the UNAIDS 1990. In Uganda, for the last 90, we're at 60%, and for the first 90, we're around 72 to 80%. We still have that challenge, and along the HIV cascade of care, and more challenges still, which are around the infrastructure and human resource. Distance from the patient's home to the health center is still great, as we've seen from Kevin's presentation. And also the health centers are being overcrowded and congested, and that's why the government is coming out with the decentralization of care. And also the healthcare work fatigue. Ugandan Academy for Health Innovation and Impact is helping to support HIV care, and its use of technology, and with this is helping in retaining the positive HIV positive patients in care, provide adherence, and also to report and manage symptoms by the patients. And all this is done through the Motec-based Connect for Life platform, which was developed by Janssen, the Johnson & Johnson pharmaceutical company. And in Uganda, this is Call for Life. Call for Life is a system which offers adherence support through a base mobile phone. We don't need a smartphone. And through this base mobile phone, we are able to give few reminders to the patients. They are reporting their symptoms. We give them appointment reminders. We give them health tips. And also, they use a secret code to be able to interact with the service. And Call for Life is able to interlink or sync with the various database, as we shall see. And we offer the services through SMS or interactive voice response. And it depends on the patient's preference. If they want SMS, that's what we offer. If they want a voice call, and that's what we offer. We ran a randomized clinical trial at IDI and at Kasangati, where we enrolled 600 participants, 300 at each site. And the population of interest was the young adults, the positive partner in discordant relationship, the most at risk, and then also those who are initiating, starting second line ART. And we're seeing this patient every 6 months. And the main evaluation was on quality of care, quality of life, which was based on the most HIV, this is medical outcome survey, and also checking the physical health scores and mental health scores. And all this was done with assessing knowledge and sexual behavior. Because we are giving health information, we needed to assess also that. Part of the results, we found that there was no statistical significance in the difference between the most medical outcome survey, HIV, mental health survey scores, and then physical health scores between baseline and month 6 for those who are receiving the Call for Life and those who are on the standard of care. When we randomized, we had 2 arms, those who are receiving standard of care alone and those on standard of care with Call for Life. In the sub-analysis, we realized that there was a difference. For those who are starting first line or switching to second line, there was a significant improvement in the physical health scores. And also there was an improvement in sexual behavior. We also found that 97% of the participants preferred voice calls rather than SMS, and this also comes to the confidentiality and privacy. When the text comes, it will just land on your phone and anyone can read it, whereas the voice call, you use your secret PIN and you interact with the service. These results have been presented to the recently concluded CROI in Seattle. In the qualitative reviews, we just give 2 examples for the patient voices, where one female participant responded that it is hard to get a doctor who cares so much for you. They ask if you have any health complaints or you report a symptom. The next day, they respond and ask you what the problem is. It is very good because we are cared for. It is good because no matter where you are, you report a symptom and they respond the following day. This happens when they report a symptom and we are able to get back to them. For the male respondent, before I had multiple sexual partners, but now ever since I was told, I realized that it's my life that I'm wasting, then I stopped. So somehow with the health information which is given, they are able to change their risk behaviors. At the end of the study, we performed a survey for both who are receiving call for life and those who are not on call for life, who are on the standard of care, and realized that 95% requested continued adherence support, even those who are already on the call for life tool. And we assessed sustainability, as you've heard, all people have difficulties in funds, and we assessed sustainability for this. And 70-80% were willing to pay to access the call for life. And the payment ranged from 200 to 10,000 shillings. At the end of the study, we transitioned to Call for Life Lite. And Call for Life Lite just gives weekly calls to stable population, that is those who have undetectable viral load. And it's operating at Mulago, at Kasanga Health Center and Chiseni Health Center. To date, we have over 3,000 participants who are receiving these calls. And we have, since 2016, we've completed around 240,000 calls. We've proven acceptability and feasibility of that tool for HIV adherence. And also, we've shown that there's an impact on quality of life for those who are starting or switching ART. And it has reduced all high-risk sexual behaviors. And lessons learned, mHealth, a great opportunity for resource-limited settings. We have already a good penetration rate for phones, and the population seems positive towards the technology. Lessons learned, infrastructure, instability, electricity, as you know, in the rural areas. Then mobile phone network in some areas also is a problem. Stability of internet, and although this is to the, not to the end user, but to the person behind the interface. Then also change in mobile phone legislation. When UCC installed the rule to register all SIM cards, we had to lose some participants for some time. Then also the bills, the IVR service bills. Then also to the end user, multiple SIM cards. People switch on from one SIM card to another. When you registered one SIM card, then you tend, by the time the call comes in, they've already switched to another. So in future, we need to capture that. Then also the stigma for SMS versus voice, and also lack of experience for those who are using the PIN codes. Next step, we are looking to extend the call for life for TB support, adherence support, looking for the youth, because we have to look for the key populations, the youth who are initiating ART. We are looking into the OPE, since already for sustainability part of it, and since people are willing to pay. And also we're looking to using that tool for follow-up on STI treatment. Thank you.
I'm here to talk about PRISMS, which is Protecting Remote Infants by SMS, 0 to 28 days. So annually we have 2.6 million under 5 deaths, and this is globally, and most of this portion is in the sub-Saharan Africa, and we find out that 96% of this is the neonatal mortalities. Then up to 75%, there are these babies who die in their first week of life due to preventable causes. So we ask a question, why is neonatal mortality still high? Basically, there are two things that could be causing this. One is that sick newborn care is considered to be highly specialized care. Then secondly is that the frontline health workers are inadequately trained to manage the sick newborns. And because of this, we realize there is a need for them to be empowered to manage the sick newborns. So we come up with PRISMS, which is a mobile application. And what this mobile application does is that it gives you a comprehensive management plan to the frontline health workers within less than 10 seconds. So as you can all see, it has different interfaces. So it is used by health workers, and when you do a baby's assessment, so we expect that every other frontline health worker should be knowing how to examine a baby and make a baby's assessment. So you input your assessment in this mobile application, and in less than 10 seconds you have a management plan, a comprehensive management plan. And everything you see in blue has additional information. It could be educative. It can tell you what you're supposed to do in case you don't know if you have something that was wrong in your assessment. Let's say maybe you don't know how to mix 10%, or you don't know how to mix any of the drugs. It will tell you how to mix your drug according to the age of this baby, according to the weight. So that is what PRISMS does. So we did a study, a feasibility and acceptability study of this application, and our objectives, the first objective was that we wanted to evaluate the feasibility and acceptability among the health workers. Then the second objective, we also wanted to know the acceptability and feasibility in using the PRISMS app by the health workers. So what happened is that in our first objectives, in our first objective, we used this in pediatricians. So we simulated cases for pediatricians, and there were 12 cases whereby we had 7 pediatricians, and each pediatrician was given 6 cases randomly to manage. And then after they've managed these cases with their knowledge, expertise, and experience, we give them the application to use and manage. And then at the end of the day, we also gave them questionnaires about the PRISMS app. And our target, we wanted to know the qualitative and quantitative use of our PRISMS, and also we wanted to see if it will generate the same management plan as what they would have done for these babies. Then we also, in our second objective, we went to a remote health center and we looked at real cases. So we gave the frontline health workers the application, and then they had to use the application on real babies, and we also gave them the questionnaires about the use of the app. And we wanted to know if it's feasible and acceptable for them to use the app in their health facility. Then our results, we found out that according to the management plan, there was less time used when the pediatricians were using prisons than when they used their knowledge and expertise. Then we found out that 6 of the 7 pediatricians recommended prisons to be good or very good to be in use. Then we also, our questionnaires had different questions, and this is what came up. If we look at, we have like, when we talked about the investigations that could be done, it was 100%. What prisons had and what they could recommend was 100%. Then we have, like when we talked about can prisons be used in hospitals, it was about 80%, and more results concerning our questionnaires. So we also looked at who should be used in prisons. Should we give it to the medical doctors? Should we give it to the clinicians? Maybe the clinical officers? Should we give it to the midwives? So this is also what we got, and we found out that medical interns were recommended highly to use our prisons, following the medical officers, and then the midwives and nurses, and also the clinical officers. And the overall was that all pediatricians recommended this phone application, and then 5 out of the 7 said that prisons was taking less time than what they have always been doing in terms of assessing and getting a management plan. Then we also got that 6 out of 7 were able to say that prisons gave them feedback in less than 10 seconds, and that was a real good time. So currently we are doing a randomized controlled trial study in 14 health facilities, and we've deployed in the Rwenzori region and the central Uganda, and we are about to analyze our data set. But this has come up with some challenges, because sometimes you go to these facilities and they feel you're just doing the research. So you're giving them the application, but they're not going to use the application because they feel you're making a lot of money out of your research. You're just doing it for yourself, and it's not helping. Then also the other challenge is the funding. So you need to visit these facilities maybe minimally on a monthly basis to find out what could be the challenges, what they are using, and how is it helpful, how can you improve, because prison started way back in 2013, and every other time we've been developing to reach to where we are now. So we need to continuously go there, and maybe at the same time look at what quality improvement can you do. So that is what prisons is about, and thank you very much.